All right, let's get right into it. Today, we're going to put you in the hot seat for consultant-level general surgery viva. I'll be your examiner, and the case we're tackling is a pretty complex bariatric complication. Ready? Let's begin. Okay, here's how we're going to break this down. We'll start with the case presentation, move through the workup and what happens in the OR, then talk about complications, and finally, we'll hit the key takeaways you absolutely need to know.
All right, the stage is set. Let's see what you've got. Your examination starts now.
So you've got this patient in front of you. What I'm really looking for here, right off the bat, is a structured, logical approach. How do you start to unpack this? What's going through your head? What are the immediate possibilities that jump out at you? Okay, that's a reasonable start. Now let's dig in. Walk me through it. How are you going to work this patient up? What's your systematic plan to figure out exactly what's going on here? This table right here, this should basically be your mental checklist the second a patient like this comes in. And you really want to pay attention to that diagnostic clue for a bowel obstruction, that cutoff of contrast on the CT scan. That's a huge clue, and it's going to be super important here. This is your foundation. And there it is. The CT confirms our suspicion. You see that cutoff of contrast, which means the bowel is completely blocked. This is not a wait-and-see situation. This is a full-blown surgical emergency. So what do you do now? What's the move? All right, before we scrub in, let's take a quick step back. Any good examiner is going to test your broader knowledge here. It's not just about this one case, you've got to know the whole landscape. So let's quickly review the common bariatric procedures. So take a look at these two. On the left, you've got your classic Roux-en-Y gastric bypass. See that tiny little stomach pouch and the new roux limb that bypasses the rest of the stomach? Now on the right, that's the sleeve gastrectomy. It's all about restricting the size of the stomach itself. Knowing this anatomy, inside and out, it's absolutely non-negotiable. You know, it's one thing to know when to do a surgery, but it's just as crucial to know when not to. And for both the sleeve and the older gastric band, what's the big one? Severe GRD. Yep, both of these can actually make reflux worse, so you're just asking for trouble with those patients. Okay, we're in the OR, the patient's on the table, we found the internal hernia, and the bowel looks compromised. You've made the call to do a subtotal gastrectomy. Now, talk me through it. What are the key steps you're going to take? Okay, this is a really solid step-by-step plan. You're starting with the incision to get in, getting good exposure, then carefully taking down all the blood supply before you do the resection. This is exactly the kind of clear, organized thinking I'm looking for. Now for the reconstruction, the details really, really matter. We're talking a 20-centimeter roux limb and a second connection, the jejuno-jejunostomy, about 60 centimeters down from the first one. But listen up, because this is the most important part. Step 5, closing all the mesenteric defects. This is almost certainly what was missed in the first surgery, and it's the entire reason we're here today. It is absolutely non-negotiable. Okay, the operation's done. But you're not off the hook yet. A great surgeon is always thinking ahead, anticipating what could go wrong. So let's talk about that. Let's look at some common post-op complications you might see. Yeah, you don't see as many gastric bands these days, but you still have to know how to handle their complications. An acute gastric prolapse, this is a huge one. It's a true surgical emergency because that part of the stomach can lose its blood supply and die. The signs are classic: sudden, terrible pain, and they can't swallow a thing. You have got to spot this right away. So how do you handle it? Well, the plan is pretty straightforward. First thing you do is try to fix it without surgery. Just pull all the fluid out of the band to deflate it. A lot of the time, that'll do the trick. But if the symptoms don't get better, you've got to go to the OR laparoscopically and fix it. It's that clear, stepwise approach that examiners want to hear. Okay, let's run through a few more common issues. A marginal ulcer, you're thinking PPIs. An anastomotic stenosis, where the connection gets too tight, that's an endoscopic balloon dilation. Now, here's a tricky one. A staple line leak after a sleeve. Location is everything here. A proximal leak up high, you can often manage that with a scope. But a distal leak down low, that's much more likely to need another trip to the OR. It's these kinds of nuances that show you really know your stuff. And hey, don't forget, your job isn't done after they leave the hospital. Not even close. These patients are at a huge risk for major nutritional problems. We're talking iron, B12, vitamin D deficiencies, you name it. This means they need lifelong supplements, and you've got to keep a close eye on them. It's a huge pitfall for candidates to miss this point. Whew, okay, we have covered a ton of ground. Let's boil it all down to the absolute must-know, high-yield points you need to take away from this.
If there is one thing you remember from this entire case, let it be this. An internal hernia after a Roux-en-Y is, for all intents and purposes, a technical error. Those little gaps in the mesentery that get created during the surgery are basically traps waiting for a piece of bowel to slip into. You have to close them, every time, no exceptions.
And these are your do not pass go red flags. These are the situations where you have to act immediately. Acute gastric prolapse after a band or a bowel obstruction after a bypass. These are surgical emergencies, plain and simple. There is no let's watch and wait. The only correct answer is the operating room. And with that, your Viva is over. You did great. But I'm going to leave you with one last thing to think about. What's the single most important conversation you need to have with a patient before they even consider one of these malabsorptive operations? Because remember, being a surgeon is about so much more than what happens in the OR. Thanks for joining me on this.